Hey guys, welcome to our lesson on psychiatric and behavioral disorders. Many of the topics that we've studied so far up to this point have had objective diagnostic criteria. For example, you know that a tachycardic patient is someone who has a heart rate greater than 100 beats per minute, bradycardia is less than 60 beats per minute. But with behavioral and psychiatric emergencies, they're not so clear cut. And because of that, they have patient presentations that will include a number of different components that it's going to require a complete patient history, physical exam, and skilled approach to the situation. Another significant difference between behavioral and psychiatric conditions from other types of medical emergencies is that most of your assessment and care will depend on your people skills, your soft skills. You can evaluate bradycardia with a cardiac monitor and treat it with atropine or pacing. In the psychiatric emergencies and behavioral disorders, most of the care you're going to provide is going to be based on observation of the patient's behavior, by interviewing bystanders and family, talking directly with the patient. Your care, which is primarily going to include some emotional and supportive care, requires a strong set of interpersonal skills to be able to communicate effectively with your patient. Topics that we're going to use for this lesson will include general behavioral emergencies. We'll talk about pathophysiology of specific emergencies. We'll talk about the assessment for a behavioral emergency patient, and what type of specific psychiatric disorders that exist, along with management for those emergencies. We'll also talk about violent patients and restraint. One of the things that we find that are probably the most disturbing is when it comes to restraint. Patient restraint is very common in EMS. However, we find that little to no education occurs in proper restraint technique or managing violent patients. We also know that EMS providers are one of the most victimized providers or abused providers in any of the healthcare settings. And so we'll dive into those with some additional videos online. So when we think about behavioral emergencies, the question always arises, can you medically treat behavior? Can you truly medically treat behavior? Well, the answer is yes, and the answer is no. Let's get into what is behavior, normal and abnormal, before we define that. Behavior is generally going to be based on what is considered to be normal or abnormal behavior. These are things where society provides a significant amount of input into what is socially appropriate or not. Indications of a behavioral or psychiatric condition include one of the three following components. First is that their behavior interferes with core life functions. They're not able to take care of themselves, either in hygiene or provide adequate food, different things of that nature. The other part that we look at is that the patient's behavior poses a threat or a risk to threat or well-being to the patient or others around them, right? They're a danger to themselves or others. And that obviously allows for us to tell that they are falling outside of what is considered normal. And lastly, behavior that deviates, again, significantly from what society, what their expectations are for normal. There's a lot of patients that will fall outside of what society deems normal, but that does not necessarily mean that they are incompetent or are suffering from a behavioral emergency. There's more to it than just that. Let's dive in a little bit deeper yet. When we think about pathophysiology of psychiatric disorders, we have to recognize that mental health problems are very common. We're going to see a lot of mental health related issues in EMS because of the lack of resources that are available, and then typically non-compliance with medications used to treat this. We know that most patients who suffer from disorders function normally on a daily basis, and a lot of times that's where medication will come in. But it's when the patient decides to get off their medications or no longer is compliant with their doctor order that oftentimes we'll see a behavioral emergency begin to arise. Now, there's a number of causes that we can see from behavioral emergencies. The first is organic, or what we would refer to as biological. For many years, medical practitioners have used the term biological and organic interchangeably when they're discussing the types of psychiatric disorders whose causes are physical rather than purely psychological. They result from the disease process such as infections and tumors, or from other structural changes in the brain, such as those brought on by abuse, alcohol, or drugs. We also know these can be based on age-related changes, drug abuse, and then neoplasms, the idea that there's some type of new growth in the brain that's not supposed to be there. Remember, when we think about organic or biological, these are naturally occurring components based on the individual, their environment, their substance abuse, things of that nature. Causes of disorders include psychosocial. These are causes related to the patient's personality style, unresolved conflicts, or crisis management methods, how well they truly are able to cope with stressors. We know that psychosocial can be brought on by their environment, stresses in their environment, or lack of security in their environment, childhood trauma, as we've discussed in our abuse and neglect chapter, including things like parental factors, being abused. Remember, that's a cycle that continues. Alcohol abuse or drug use as well. And then brain chemistry components that lead into alterations in normal brain function. And again, some of these are genetically predisposed as well, as we talked primarily about brain chemistry. Social cultural, now we're talking about causes that are related to the patient's actions or interactions with society. Maybe it's based on their social economical status, right? How rich or poor they are, depending on their social habits. Knowing that there's a lot of issues that are going on with social components throughout the United States due to COVID-19 and social distancing. How well do they handle their social skills? Are they able to maintain relationships? Are they able to hold a job? Or do they suffer from some form of discrimination? Let's go ahead and get into assessments of behavioral emergency patients. When we deal with behavioral emergencies, one of the big things we have to recognize are soft skills. And I always like to ask the students in class, what are soft skills? Soft skills, in essence, are skills that are not necessarily technical in nature. These include things like communication, empathy, your affective behavior, your professional behavior, and how you carry yourself, and how you care for your patients. We know that with assessments for these types of patients, scene size up is probably one of the most important components that you're going to have, and this really is because we know that the scene in a behavioral emergency can change at any moment, and so our ability to clearly assess and recognize what's going on in the scene is going to be of the utmost importance. Again, your head should be on a swivel, constantly paying attention to what's going on around you to ensure your personal safety. Your initial assessment is really going to focus on the primary components that it always has. We know that, again, there's a lot of different issues that can happen, medical conditions and traumatic conditions that can go along with behavioral emergencies concurrently, and so we want to be able to recognize some of those things. We want to pay attention to how your patient presents. Do they present with any life-threatening emergencies? If so, those require immediate attention. And then remember to assess and manage your airway, breathing, and circulation, your primary assessment, as best as you can. We also know that we want to make sure that we're focusing on your general impression. The general impression is really going to give you the most information without actually just talking with your patient. We're wanting to pay attention to things such as posture, fear, maybe some confusion, any emotional response, rage, anxiety, as we try to be able to recognize that. We want to try to have a sense of their visible indicators of their mood. These could include things like posturing or hand gestures, signs of aggression. We want to, again, observe their awareness, their orientation, their cognitive abilities and affect, and then consider the patient's emotional state. We know that general impression is going to be one of the biggest things that you're going to have to really focus in on. When you're questioning your scene, we're going to talk about some ways that you can effectively do that, but your general impression should be one of the first things to prepare you for dealing with a patient suffering from a behavioral emergency. Your focus, history and physical exam, we're going to go ahead and listen to our patient, or ask open-ended questions, spend time with them, listen carefully to what they have to say. And remember, no one likes being ignored. So ignoring a patient or pretending to hear them or pretending to listen oftentimes will exacerbate a problem. When you need to be informed, you need to listen. We also want to make sure that we spend time rushing patient answers, oftentimes cutting them off. Can lead to a lot of frustration, feels that you're in a hurry or that you're not concerned about them, and oftentimes the patient will shut down and stop answering questions. You want to be assured, communicate self-confidence, be honest to your patients, so never give them any false hope, and then remember to be a professional. Don't threaten them. That's extremely important. Avoid rapid or sudden movements or questions that patients might interpret as threats. Remember, also approach your patient slowly but with confidence. That's going to help you de-escalate that situation. Place your, let me back up yet. Don't fear the silence. As a test. Don't fear the silence. Silence is okay. Silence is appropriate. Encourage the patient to tell us stories, but don't force things out of them, right? Don't antagonize them to get more information about what has happened. Let them talk if they need to. You can listen and then empathize with them. Also, place yourself at the patient's level. This needs to be done safely, but we know that standing over the patient oftentimes is going to lead to an intimidation factor. And we want to break down those barriers. But do not position yourself where you cannot respond appropriately if there's some type of danger or attack. You want to be out of arm's distance, right? But at least at eye level. And try to appear as comfortable as you can. If you feel uncomfortable, they're going to pick up on that. They're going to play off of that. Don't appear judgmental, right? Be careful what you say or who you say what to or what's happening around you, as those things can escalate the scene as well. And never lie to the patient. Don't give in to that. That false hope. If they're hallucinating, don't tell them you see things. You can tell them that you believe they see things, but don't feed into those to say components of, well, I also see those birds, or I see those bats, or I see an alien ship, or whatever it is. You can say, I believe that you see those things, but I don't, and I think we need to give you some help. Feeding into that will lead to a lot more problems later on. Most of the things we think about with your general assessment we talked about here, paying attention to general appearance, paying attention to a whole number of different components of behavioral observations, orientation, memory, sensory, perceptual processes, mood and affect, again, intelligence, thought process, insight, judgment, and their psychomotor control. We know that a lot of times psychiatric and behavioral emergencies lead or come to fruition because of a lack of compliance with their prescribed medications. And so as we recognize that, it's important for us to make sure that we have the ability to recognize what are common meds that we might see. Lithium, Lithobid, Depakote are a number of the common ones you might see for things like schizophrenia or paranoid or disorganized, catatonic, or undifferentiated types of schizophrenia. The question you want to ask your patient is compliance. Are you taking your medications as prescribed by your doctor? And a lot of times some patients are going to receive periodic dosing due to dose compliance, or poor compliance. So they may get an additional increase in script or increase in strength of medication to offset their poor compliance. When we deal with specific psychiatric disorders, we're going to go through a number of them, but they're going to be classified first off by disorders related to cognitive function. Psychiatric disorders with organic causes, such as a brain injury or disease. We may also see delirium and things like dementia. Now, we've talked about this before, but we have to remember that delirium and dementia are two different things. Delirium is a rapid onset of widespread disorganized thought. That could be because of drug use. It could be because of some other underlying condition that's now manifesting and causing an acute problem. Delirium is acute. Dementia is a prolonged chronic problem that will gradually deteriorate their cognitive ability and memory ability. We see with dementia common signs such as aphasia, apraxia, agnosia, disturbances in executive functioning, the ability to care and treat for themselves. Schizophrenia, on the other hand, are going to be symptoms that are related to delusions or hallucinations. They become disorganized in speech, grossly disorganized with their behavior or catatonic-like behavior, and then even things like a flat affect or flat concern about how they interact with those around them. Typically, we think of this as from the movie Beautiful Minds. It's a great, if you haven't had a chance to watch that, please do, because it's a great movie. But it does allow us to kind of wrap our minds around what it's like to deal with someone who's suffering from schizophrenia. We also know that the schizophrenia that we deal with is going to be focused primarily around the different types that we see. Your paranoid schizophrenia, they have feelings of persecution, delusions, auditory hallucinations, disorganized, we're talking about behavior in dress or speech, catatonic, that could be muscle rigidity, immobility, it could be a stupor, or even odd involuntary movements. And then undifferentiated is just those that do not fit into one of the other three classifications of paranoid, disorganized, or catatonic. To diagnose with schizophrenia, you have to have at least 2 or more symptoms, and they have to be present for each over a course of 6 months. We also have to recognize that not only do you have to have 2 of those major symptoms for at least 6 months, you also have to recognize that it has to have an impact on your normal daily function, either social or occupational dysfunction. Can't hold a job, can't meet requirements for life or family, those different components. Care for these, again, all of these are going to be supportive and non-judgmental care, the soft skills we talked about. We do not want to reinforce the patient's hallucinations, so don't feed into them. If they tell you they see something that's not there, tell them you believe them, but you don't see those things, or you don't hear those things. Recognize that if we feed into those, yes, it may give us some leeway in the meantime to get them into the ambulance or the hospital, but from that point on, you are going to embed a permanent doubt that they believed you, and now all of a sudden at the hospital they don't believe them, and so they must be part of this scheme. They must be working against me because, well, geez, the paramedic did believe me. So remember that a quick reaction to get your patient to go to the hospital oftentimes can lead to long-term consequences in their ability to gain adequate mental health care. We also want to make sure we speak open and honestly. Don't hide things. Be honest about what's going on, and then always remain on alert. Your head should always be on a swivel. Panic attacks and anxiety-related disorders. Panic attacks can happen to anybody. They're based off extreme periods of anxiety that result in great emotional distress. When we think about panic attacks, we often have to try to recognize what else could the problem be if it's not a panic attack. How do we differentiate a panic attack from other medical conditions? Well, we know that oftentimes it can resemble a cardiac condition or a respiratory condition with the rapid breathing and labored breathing. We also know that the patient may also have a condition of pre-existing anxiety that we may need to get more information on. We have to recognize that, again, these folks are going to be having some major concerns for at least 4 symptoms peaking within 10 minutes. Some of the symptoms you would see of a panic attack include palpitation, sweating, trembling, or shaking, paresthesia, chills or hot flashes, shortness of breath, or feelings of being smothered or choked. They're going to have derealization or depersonalization, where they just feel disconnected or not part of what's going on around them. They may have chest discomfort or chest pain, dizziness or unsteadiness or lightheadedness, nausea, abdominal distress, or fear of losing control, that they feel like they're going crazy or that they're dying. And that oftentimes all of these are going to just reaffirm the panic condition that they're suffering from, making it harder for them to focus. One of the things that I don't see on the slide that I feel is very important are what are called carpal pedal spasms. Carpal pedal spasm is when we have such fast breathing that we hyperventilate and we begin to blow off excessive amounts of carbon dioxide. When that happens, it causes cramping, muscle spasms, primarily in your tarsals and metacarpals, and so because of that, you start to get these weird cramping, like claw hands. I was like, grab a strong hand. But the idea behind that is that actually makes their problem worse, because now their hands are cramping, their feet are cramping, they feel like there's something really wrong. Well, it's because they're hyperventilating. So we have to kind of recognize that as an additional sign. Treatment-wise is going to be to calm them down, show empathy, and be supportive. Reassure them to slow their breathing. Be aggressive when it comes to trying to get them to slow their breathing. Look them in the eye, use their name, tell them to stop, and breathe with you. Sometimes being aggressive to get their attention will be helpful. Sometimes it may make things worse, so to kind of read your patient. You can consider some sedative medications, Ativan, Valium, believe it or not, even Benadryl, as far as some form of antihistamines as a sedative effect. Ketamine is also a potential choice if we're getting to that really severe side. We just have to remember when we're dealing with these patients that the most effective way to control it is to remove them from the stressful environment and then control their breathing and do the best you can to coach in that nature. We also know that with anxiety-related disorders, there are phobias, right? And so it's an intense, irrational fear that interferes with their regular functioning. Management for a patient with phobia is often just going to be supportive. If they're hallucinating and they're seeing spiders and they're afraid of, they have arachnophobia, then again, we'll have to know that those items are not there, but those are going to feel very real to those patients. PTSD is something that we in EMS oftentimes will talk about in relation to those who serve in wartime condition. We think of our Afghanistan, our Iraq veterans, things of that nature, Vietnam even for that matter. The idea behind it is that PTSD goes well beyond the military, well beyond wartime participants. It goes on to you and I as EMS providers, to those who have suffered from natural disasters or major losses and catastrophes in their life. All these things can lead to an onset of post-traumatic stress syndrome or post-traumatic stress disorder. We know that this is, in essence, is a reaction to extreme life-threatening stressors. The characteristics are common: recurrent, intrusive, couldn't get that word out either, intrusive thoughts, sleep disorders, nightmares, things of that nature. We also know that we may have those that did not die, but they may have suffered from what we call survivor guilt. But if they're the only one to survive an incident, oftentimes they're going to have remorse for that. And then we know these people generally will lead to some type of substance or substance abuse problem to mute the feelings that they're having, to try to cope with those feelings. We've got to remember that anyone that suffers from PTSD needs to be treated with respect, empathy, and then support. It's about the most important thing we can do for them. And recognize that we too can suffer from PTSD. When we think about depression, the big one we look at is major depressive disorder. This is where they nearly all the time, all day, every day, they are depressed. They're down in the dumps regularly. They don't have take pleasure in regular daily activities. You see significant weight changes, either up or down. Insomnia or hyperinsomnia, so either they're not sleeping or they're oversleeping excessively. They will feel worthless or have feelings of excessive guilt. And then they're diminished by their ability to think. They're very, very indecisive because of that. And they will suffer from recurrent thoughts of death, either harming themselves or thinking of what it would be like if they were dead. In order to be diagnosed with major depressive disorder, it's going to require 5 or more symptoms that are present for the same 14-day period. It cannot be accounted for by other problems. So if there's other things that are going on, they're not going to use that as part of this diagnostic criteria. It has to be separate from those different components. We also know that depression can be accompanied by a lot of different things like substance abuse, anxiety disorders, and even schizophrenia. And we got to remember, those patients that suffer from MDD or major depressive disorder, they're going to have symptoms that can easily be remembered as a acronym of inside cages, as crazy as that may sound. Again, it stands for things like interest, loss of interest, sleep issues, appetite, decreased mood, concentration problems, activity, guilt, energy, or even suicidal thoughts. So inside cages is a great way to try to recall what might be the symptoms for some type of mood disorder or major depressive disorder. Bipolar disorder. Bipolar disorder gets a bad rap because people think typically it has to do with folks that are flipping a switch, right? One minute they're super hyper and manic, and the next minute, boy, they're down in the dumps, and it flips left and right just like that. That is not the case. Patients who suffer from bipolar disorder, or more appropriately called manic depressive disorder, is going to be in lows and highs for periods of time, typically anywhere between 3 to 6 weeks up to as long as 3 months or even longer. It's not a rapid switch flip. That's a different type of behavioral disorder or a coping disorder. When we deal with bipolar patients, we've got to be able to recognize both the manic and the depressive component. typically we're called more often for the manic issues than we are for the depressive issues, unless there's some type of suicidal thought or action. Most of these with your manic episodes are going to be based off inflated self-esteem, or they're going to feel this feeling of grandiosity, that they are just oh so grand and that they're invincible. They don't feel like they need to have any sleep. They get excessive energy. They're more talkative, or they're going to pressure you to talk. They may fight the ideas, flight of ideas or subjective experiences and thoughts are racing. They're going to be, their mind is moving so fast that they just can't get all their thoughts out coherently. They're also very easily distracted. You see increase in goal-directed activity, so they want to be more compliant with goals, but oftentimes they fail to meet those goals. Excessive involuntary pleasurable activities. If it feels good, they're going to do it. Drugs, alcohol, sex, those types of things, they're going to be involved in a lot because those will make them feel good. Daredevil-like stunts, things of that nature is also very common. And then delusional thoughts. Now, these may alternate with depressive episodes as well, and those we talked about as part of that depressive inside cages acronym that we use. But we have to recognize that with mood disorders such as bipolar, we're going to see that swing. We oftentimes will see a lot of medications that are going to be used to treat this. Most of the symptoms that we see are going to be based on a mixed episode. They're going to require hospitalization. They may also require making sure that the proper medications like lithium or anticonvulsants, antidepressants, antipsychotics, or even benzodiazepines can be used to help treat a number of these. When we're dealing with these these mood disorders, we've got to have a very focused management plan. For all of these, the goal is to be calm, cool, and collected. Maintain a calm, protective environment, and don't confront the manic patient. It's just going to make things worse. They think that they're invincible, they think that they are correct, and they know what's going on more than anyone else around them. So we want to try to assess and manage any of the other coexisting conditions that they may have. You may find that they may be suffering from hypothermia if they've been out, crawling through the snow with no clothes on, to dealing with other underlying cardiac-related issues from noncompliance with medications. We also know that things like medications, like antipsychotics specifically, like haloperidol, may be indicated in those who are extremely manic as well as a number of other medications that can be used. Psychological and psychosocial disorders as well are related to substance abuse. You build a dependence on the substance that they're choosing to use. Because of that, it puts them at a much more increase in abuse, right? So that we know that they're already suffering from an underlying condition of some sort, and that they're leaning onto that dependency of that substance to help them cope. And we know it's going to make the process worse. Somatoform disorders, these are going to be characterized by physical symptoms that have no apparent psychological cause or physiological cause. People who suffer from somatoform disorders believe their symptoms are serious and real, but we know that they don't actually always exist. They're not always tangible or measurable. Somatization disorder is one that we commonly would see, so the patient's preoccupied with their physical symptoms. Conversion disorder is where the patient sustains a loss in function, usually involving the nervous system, where they become blind or become paralyzed. And it's unexplained by any medical illness. It's just unknown why it causes or where it came about. Hypochondrias is another one that we see. These are folks that are exaggerated interpretations of physical symptoms that will be mocking or mimicking a serious illness. And then body dysmorphic disorder as well, where they believe the patient believes that he has a deficit in physical appearance. So they're constantly concerned about their physical appearance. And then a pain disorder, where a patient suffers from pain, usually severe, and it's unexplained. This could be an example of where you might see someone with fibromyalgia. Factitious disorders, they are sometimes confused with somatoform disorders, but they're characterized by three primary characteristics. The first is an intentional production of physical or psychological signs and symptoms. So they're creating this storyline. They have the motivation for the behavior is that they want to assume the role of being sick, right? So they want to motivate themselves to be the sick patient. We oftentimes will see external incentives for behavior, like things like avoiding police or avoiding work. They're going to come up with some underlying condition because they're sick to get out of doing something they don't want to do. Even though they're suffering from that, we know that primarily we're going to continue to give them the utmost care that we can. We can't prove what they're telling us is not true, so we need to treat it as such. The other one that we look at is Munchausen syndrome. Munchausen syndrome is going to be where it produces plausible signs and symptoms, and this is oftentimes where the patient can put together a story that will make sense, but oftentimes they know too much for their own good, is probably the best way to put it. They're knowledgeable medical treatments, they've done their research, they know what to say yes to, they know what to say no to, they know how to describe things to fit textbook style cases of a condition, even though they don't actually have them. Dissociative disorders, this is when we're talking about how to avoid stresses while obtaining gratifying needs. Psychogenic amnesia is a prime example of this, is where they just have an incident occur and they just physically can't recall. A lot of times we'll see that in patients who are trying to hide or suppress emotions or memories. A fugue state, in the case a patient in a fugue state actually flees as a defense mechanism. So they have this concern, problem, they just run, they just fly from it. Multiple personality disorder, this patient reacts to identifiable stress by manifesting 2 or more complete systems of personality. Something that's stressful, they may have a personality that deals with that. Something that's funny or happy or exciting, they may have a personality to deal with that, and vice versa. And then depersonalization is where basically the individual loses their ability to recognize themselves and who they are. Eating disorders, anorexia nervosa is another one we see. This is excessive fasting. And these are the folks that have a major concern about their body when it comes to obesity. Bulimia nervosa, this is again, we're talking about, this is binging, where they're going to eat excessive amounts of food, and then they're going to go ahead and purge. They're going to go ahead and then induce some type of vomiting to get rid of what they've eaten, to help maintain, again, that bodily figure that they want. We know that with eating disorders, weight loss and body changes experienced by anorexia and the bulimic patients can lead to serious physical problems. These include things like anemia, dehydration, vitamin deficiencies, hypoglycemia, and then cardiac-related problems as well because of the changes in electrolytes. Pre-hospital care is likely to include treatment for dehydration and then any physical problems that manifest. When we think about personality disorders, these are disorders that result in persistently maladaptive ways of perceiving, thinking, and relating to the world. They're just not going to be able to connect properly like they need to. In extreme cases, the patient's going to act out against or in attempts to manipulate society to get them to where they think that the world should be from their point of view. And there's different classifications of these. Personality disorders, cluster A, these are individuals that often act odd or eccentric. They're paranoid personality disorders, where they just have a patent sense for distress. Schizoid personality disorder as well, where the detachment from social relationships. Schizotypal personality disorders, where you're seeing discomfort in close relationships and eccentric behavior. Cluster B-wise, we're talking about, these are dramatic folks, emotional or fearful, or may suffer from an antisocial personality disorder or borderline personality disorder, histrionic personality disorder, where they have excessive emotions and constantly are seeking attention, and then narcissistic personality disorders, where they're just absolutely in love with themselves beyond all belief. When we deal with cluster C, this is often appears anxious or fearful. They're going to be avoidant personality disorders, where they don't want to be around things. They're very sensitive to criticism. They feel like they're inadequately socially. Dependent personality disorders, they're very submissive or cling to certain behaviors. They need to be cared for regularly. And then obsessive compulsive disorder. I prefer to call it CEO because that's alphabetically correct. But OCD is also the preoccupation with orderliness, cleanliness, or arranging things. I think there's some smudges on the camera. That's better. That was a joke. Impulsive control disorders, harmful to the patients who like to steal things, who would like to do fire, who have gambling issues, have a number of different components that they're dealing with as far as those go. So recognizing that when we're dealing with someone with intermittent explosive disorders, we know that recurrent and paroxysmal episodes of significant loss of control of aggressive response can occur. These guys can get very, very effective, very aggressive when it comes to that. We also know that things like klepto refers to stealing, and then your trichotillomania is where they start to actually pull out their hair. You may see that in eyebrows or the actual hair themselves. And there's that. Suicide. Suicide is pretty common, unfortunately. They're continuing to rise, especially among the young and the old. And then again, during the times that we're in right now. We know that women attempt suicide more frequently, but men are more likely to succeed. We also know that women are generally cleaner about suicide. If they're going to do something, they're going to be considerate of those who will be responding or need to clean up. Men, on the other hand, don't have that same concern. Common methods you can see, bullet wounds 60%, poisonings 18%, strangulation 15%, cutting is 1%, and then the category for all others is also 6%. With suicide, assessing potentially suicidal patients, we've got to be careful what we're looking at with these patients. We know that we need to make sure we document the things that we see, what we observe on scene, because they're going to be very valuable to mental health professionals. Document any notes, any plans, any statements, any of those things made by the patient to make sure those accompany your report or are quoted verbatim in your report. Remember, treat traumatic or medical complaints that person may be suffering from. They may be having suicidal tendencies, but also have an underlying condition that's exacerbated by a suicide attempt. We also want to look for things like notes on cars, as far as a safety concern for carbon monoxide poisoning or other poisonings. There are some risk factors that put certain populations at a higher likelihood of performing suicidal actions or leaning towards more suicidal tendencies. One is if they've had a previous attempt. If they've made previous attempts to harm themselves, it's more likely that they're a higher risk for future occurrences. We know that depression, we know that in the age groups at 15 to 24 and 40 and over, all of those can be some issues that we could easily see. They could be divorced or widowed. You may see them beginning to get rid of lots of their belongings, giving away valuable possessions that they otherwise wouldn't. Maybe they're living alone or in isolation. You know, the biggest issues we've seen with the stay-at-home order with COVID-19, and the presence of psychosis with depression. And then if they have any type of chronic illnesses such as HIV, AIDS, hepatitis, things of that nature. We also know that major separation trauma can cause concerns with suicide. We know that those that possess the mechanisms for suicide, including guns, are more likely to commit harm to themselves. We also know that loss of independence, loss of future goals, or planning for the future. Suicide is very common for those that are same sex. And we see those that express a detailed plan for suicide are more likely to commit it as well. When we talk about age-related considerations, we've got to remember that suicide and mental illness, psychiatric emergencies, know no boundaries when it comes to age. Assessing your patient's ability to communicate is important when it comes to dealing with suicidal tendencies in a geriatric population. We want to make sure that we provide continual reassurance to them. They oftentimes feel like they don't bring anything or they have no worth, no true sense of being for them. So we want to make sure that we do our best to reassure them. We know that a lot of times that they're going to compensate for patient losses in sight and hearing. So reassure with physical contact. And remember, always treat all of your patients with respect, regardless of age. We want to make sure that we recognize that geriatric patients don't tolerate medications well, especially in general because of the polypharmacy that they're already dealing with. Administering medications can oftentimes lead to more complications in a suicidal geriatric patient. Describe what you're doing before you do it to them. That's, again, can be because of sensual problems such as vision or hearing. Take your time with what you're doing and allow for those that comfort the patient to be near them, friends or family, whenever possible. Try not to separate young children from their parents. If we're talking about peds. Keep them with it. That's going to make them calm. Oftentimes it may escalate situations, so you have to read that carefully depending on the age and situation. Prevent children from seeing things that will increase their distress. If something is agitating them, keep it away. If they don't want to see mom, keep mom away or dad away. Make it appropriate, but recognize that we don't want to exacerbate what's already going on. Keep your explanations brief. Too much information is going to cause overload, and it's going to scare them. Remember to be calm and speak slowly. Identify yourself, and as always, be truthful with children. If it's going to hurt or cause issues or concerns, be honest with them. They'll respect you more in the long run. And encourage kids and children to help with their care. The more you involve them, the more information you'll get out of them. We also oftentimes will recognize that by reassuring children that we care, by carrying out all of our interventions as gently as we can, right? Being conscious of lifting the cot or loading the cot. Those little things show that we care about them by just trying to be gentle. We also know that we want to make sure that we allow children to cry or show emotions if it's appropriate. If they're crying, we don't need to have them stop. We need to be supportive. If we have to separate the children, we want to make sure that we introduce the next person who will assume your care. So when we do turnover of care, it can't be just a drop-off. It's got to be an introduction to who their nurse or their PCA is, doctor, what they're going to be doing, and build a rapport with them so you can transfer over that care and maintain that trust that you've built. Let them take something with them that comforts them, either a favorite blanket or a favorite toy, and never ever leave anyone alone who is having suicidal or behavioral emergencies. We've talked a lot about specific disorders already, but we'll go ahead and continue to talk about excited delirium. We know that excited delirium appears to be a factor in sudden death associated with restraint. These folks are suffering from a drug intoxication or a psychiatric illness or both, and those things can compound on your cardiovascular system to the point in which it can actually collapse. Now, signs and symptoms of excited delirium include things like unexpected strength and endurance, apparently without fatigue. We also notice that it's going to be an abnormal tolerance to pain. They may feel hot to the touch and have actually even taken off their clothing because of that. They're agitated, they're sweating profusely, they're hostile, and they have very strange and bizarre behavior and speech. With excited delirium, we always have to be concerned about how we're going to transport that patient and how can we safely transport them. Is there a need to restrain them with physical restraints, or is there restraints that we can use that are chemical in nature, such as ketamine, benzodiazepines, things of that nature? Having a low threshold for using chemical restraint is probably your safest bet. Allowing a patient to struggle against some type of mechanical or physical restraint is what's going to lead to sudden death. Sudden cardiac compromise leads to inability for them to have adequate perfusion and leads to death. So consider sedation. That's probably one of the best things that you can do to get through that. When we're dealing with the management of specific emergencies, there's some general procedures that we need to follow. First, safety, safety, safety. Your safety, your partner's safety, the public, all those are going to be very concerning when you're dealing with a behavioral emergency. We also know that we need to ensure a calm and supportive environment. We want to treat any existing medical conditions that may be presenting, and do not allow suicidal patients to be alone. Do not confront or argue with them. Provide realistic reassurance. Be honest with them, be simple and direct. And then make sure when you transport them that you're taking them to an appropriate facility. That may include medical issues where there's they may be suffering from a behavioral component because of an underlying problem. This could be for overdose, it could be lacerations, toxic inhalations, hypoxia, metabolic conditions, whatever is underlying its medical, treat it. And for psychological concerns, build trust, use good interviewing skills, and don't talk down to the patient. You can see that there's a number of things between being calm and cooperative, from being one extreme totally withdrawal to totally combative. Know where your patient falls in the continuum of emotional states and be prepared for them to become combative if that is the case. Now, when we're dealing with violent patients and restraints, there's a couple of key things that we need to know. Restraint a violent patient at an emergency scene is a controversial aspect of what we do in modern EMS. Patient restraint in the emergency medical services system is one of the things that we typically will deal with. And we have protocols that specifically outline what and how we can deal with these patients. Now, most of these patients, when we think about how we're going to do this, we're going to try to do it in a very systematic format. We're going to try by de-escalating the situation verbally. We know that that doesn't work. Physical constraint may be necessary. So verbal de-escalation is probably the most important things, right? That's the first thing that you should employ upon arrival. Conversation must be honest and straightforward. It needs to be with a friendly tone. Avoid direct eye contact, things of that nature. Don't encroach in the patient's personal space, but do the best you can to give them what's going on, an idea of what's going on, and try to diffuse the situation. If that fails, we're then going to need to move to physical restraints, potentially. When physical restraining a patient, paramedics must make every effort to avoid injuring the patient. The patient restraint policies must therefore recommend restraint devices that are associated with the least chance of inflicting injury. Patient's restraints is accomplished with materials and techniques that will restrict the movement of a person who is considered to be a danger to himself or others. These include things like soft restraints, sheets, and or wrist or chest posies, and then hard restraints like plastic ties, handcuffs, and leather restraints. It's important to know that for us here in Michigan, we are allowed to use only soft restraints, and again, that needs to be in compliance with your local MCA and your restraining protocols. When you're doing this, it's extremely important that you have a planned approach, that you communicate what's going on to your patient. You assign one rescuer to each limb, including the head, and then you keep communicating with the patient as you go down. Once you go down, you want to move the patient into a supine position on the stretcher. You can see in this case they've got a position when one person's arm is up, other person's arm is down. We also want to use soft restraints to secure the patient. No backboards, no other components, nothing over their chest, nothing that would impede their ability to breathe, or for you to assess or manage the patient in case they were to fall into a cardiac-related emergency. Be very conscious of reassessing their airway, breathing, and circulation. Watch for signs of positional asphyxia, and never, ever hog-tie a patient or use any type of hobble restraints. For chemical restraints, we want to make sure that we're doing the administration of specific pharmacological agents to decrease agitation and increase cooperation of the patient. Remember, the goal is to subdue the excessive agitation and struggle from against those physical restraints. A number of medications that you can see, benzodiazepine-wise, there's your Haldol, diazepam, midazolam, lorazepam, and ketamine as well. So in summary, when we're dealing with behavioral emergencies, we have to recognize that we have to treat the patient as a patient, recognizing that it's no different than any other medical condition that we may be dealing with. We must also recognize that safety is one of the utmost important components we have to ourselves and to our patient. We have to recognize there's a number of things that can cause psychiatric or behavioral emergencies, and so our assessment needs to cover a wider range of common concerns and illnesses. We have to have a strong basis in the specific psychiatric disorders that you may come across, and then be able to manage those appropriately, with most of the management being keeping the patient calm, comfortable, and safe. And when those cases occur where we have to restrain a violent patient, either physically or chemically, that we do so with the utmost concern and caution, focusing on our patient to not make the problem worse, but to recognize that the restraint is to prevent them from harming themselves further or harming others. And so with that, I'd like to conclude this lesson, and I look forward to seeing you on the next one.